I, Lieutenant Colonel Naseem Yadav, welcome you all to today's Saturday clinical meeting. Start.
My patient is a 68-year-old male, resident of Haryana, education till the 10th standard, occupation retired general duty soldier, informant is self, and reliability is good. He presented to the respiratory OPD with complaints of cough, expectoration, and progressive breathlessness with wheezing of 2 years duration, and 3 days history of fever, increased breathlessness, and yellowish expectoration. The cough was insidious in onset, no aggravating or relieving factors, no diurnal or postural or seasonal variation, no specific triggers.
Major Parkhar, how do you define chronic cough? Okay. And what are the common causes of chronic cough? If we divide it into intrathoracic and extrathoracic, what are some common causes of intrathoracic cough? Intrathoracic causes of cough.
Sir, any infection of the parenchyma like tuberculosis can cause chronic cough.
What else?
Pneumonia can cause chronic cough.
That will not be chronic, na? Any airway diseases?
Bronchitis can cause chronic cough. COPD can cause chronic cough.
Captain Shashi. What are some causes of intrathoracic causes of chronic cough?
Sir, there will be bronchiectasis, sir. Bronchiectasis, bronchitis, asthma, sir, and
Major Kesu. Tell me some extrathoracic causes.
Drug induced.
Yeah, take better. Next. So the common causes, the common intrathoracic causes include tuberculosis, asthma, COPD, and bronchitis, left heart failure, interstitial lung disease, and carcinoma lung. While the extrathoracic causes include upper airway cough syndrome, gastroesophageal reflux, as told medications, and chronic allergic rhinitis. Next.
My patient also had expectoration, which was mucoid in consistency, 1 to 2 teaspoons per day, non-foul smelling, no diurnal, postural, or seasonal variation, and increased in volume and purulence over 3 days. His breathlessness was insidious in onset, gradually progressive from MMRC grade 1 to 3 over 2 years duration, associated with wheeze. No diurnal, seasonal, or postural variation was present. There were no triggers, and had increased to MMRC grade 4 since 3 days.
Captain Shashi, what are the common scales of dyspnea that you know of? Captain Shashi.
MMRC, sir, NOAH, board index.
What? What was the last one that you told?
Broad criteria.
ठीक. Major Dipakar. Common scales of dyspnea that we use.
MRC, sir, MMRC, and NYHA.
Sit. So the common causes of dyspnea are MRC scale, MMRC scale, NYHA, visual analog scale, BOG scale, then Shedwood-Jones grading, ATS scale, and St. George's Respiratory Questionnaire. Can you tell me the various grades of breathlessness as per MMRC? Major Ashwin?
Sir, in grade 0, the patient is not troubled by breathlessness at all. In grade 1, on hurrying up a level ground or if he's climbing uphill, he gets breathless. On grade 2, sir, if he walks slower than his contemporaries or the individuals with same age, or if he walks the same pace, after some time he has to slow down. In grade 3, he gets breathless not walking 100 meters, 90 meters or 100 feet. And
100 yards.
Yeah. 100 yards. and in grade 4, he gets breathlessness even at rest, sir.
ठीक है बैठिए. So next.
My patient also had fever, which was 3 days duration, intermittent, with a maximum temperature of 101 degrees Fahrenheit, not associated with chills, rigors, or sweating, and relieved with medication. He gave no history of hemoptysis, orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitations or syncope, distension of abdomen, weight loss, and anorexia. There was no significant medical or surgical illness in the past. Patient was being managed for occasional flare-ups with the nebulized and injectable medications. He was also prescribed an inhaler by a civil medical practitioner for use on as-needed basis. In his personal history, he consumed a mixed diet, reformed BD smoker with a smoking index of 400, abstinent for 15 years. He did not consume alcohol and had normal bowel and bladder habits.
Major Satish, how do you define smoking index?
Number of cigarettes per day multiplied by years for which you have smoked.
And how do you quantify the amount of exposure as per mild, moderate, and heavy?
More than 400 is severe, 100 to 400 is moderate, and lesser 100 is.
ठीक है. So as per the original article, less than 100 is mild, 100 to 300 is moderate, and more than 300 is heavy. But
There were no similar illnesses in the family.
Major Sudhin, can you summarize the case?
Sir, in male presented with cough and breathlessness. Sorry, I missed.
Surgeon Lieutenant Colonel Shamsha.
Sir, the 64-year-old male presented with cough and breathlessness, sir, with chronic duration of cough and breathlessness with intermittent wheeze, sir, and he is a heavy smoker with no other comorbidities, sir.
He is a reformed smoker.
He is a reformed smoker with no other comorbidities, sir.
So the patient was a 68-year-old male, former smoker, presented with complaints of cough with mucoid expectoration, breathlessness, and wheeze of 2 years duration, with 3 days history of fever, increased breathlessness, and purulent expectoration. How do we localize where the pathology lies, whether it is in the parenchyma, the airway, the pleura, or the vasculature? Na? So, as per the symptoms, Dr. Kanti.
Chronic symptoms of wheeze and
Yeah, if there's breathlessness, so what are the part of the lungs that can be involved?
alveoli, sir, airways.
Yeah, airways, parenchyma, also,
Parenchyma.
interstitium also.
Yes, sir.
ठीक है. Cough होगा तो what are involved?
Bronchitis and bronchi and
In
airway.
that also parenchyma as well as even pleura can also be.
Yes, sir.
In wheeze, what can be involved?
Alveoli, sir, obstructive
Airways.
airways.
If wheeze is there, the disease is localized to the airways. ठीक. And if hemoptysis is there,
Vascular.
it can either be vasculature or airways or parenchyma. ठीक है, बैठिए. Next. What are the possibilities at this stage? Dr. Firdosh?
And sir, given the history of chronic cough with expectoration, sir, and breathlessness, sir, sir, but this can be, sir, one of the COPDs.
What else?
It can be bronchiectasis also, sir, and then if we talk about infections, it can be tuberculosis, sir.
ठीक है, बैठिए. Next. These are the DDs that we are considering at this point, including COPD, bronchitis, ILD, and carcinoma lung. Next.
My patient's weight was 58 kilos, height was 170 centimeters, BMI was 26 kg per meter square, heart rate was 102 per minute, respiratory rate was 36 per minute abdominal thoracic, blood pressure was 142 by 80 millimeters right arm supine, SpO2 was 78% on room air, which increased to 90% on 2 liters per minute by nasal prongs. Temperature was 100.5 degrees Fahrenheit with bilateral petal edema present. JVP was not traced. There was no pallor, icterus, sinuses, clubbing, or lymphadenopathy. And his upper airway examination was normal except for poor oral hygiene and nicotine staining present over teeth. In the respiratory system examination, the patient had use of accessory muscles of respiration. On palpation, his trachea was central. Apex beat was localized over the fifth intercostal space, 1.5 centimeters medial to the left mid-clavicular line. There was hyperresonant note over all lung fields. Sternal percussion was resonant. Liver dullness was over the right seventh intercostal space with a tidal percussion of one intercostal space. On auscultation, polyphonic wheeze was heard over all lung fields. In a systemic examination, except for loud P2 in the cardiovascular system, there was no other significant findings. In clinical diagnosis, he had an obstructive airway disease associated with hyperinflation with features of pulmonary hypertension and respiratory failure. And amongst the possibilities, that excluded ILD after clinical examination. In his investigations, his hemoglobin was 11 grams per deciliter, TLC neutrophils were 86%, his ABG revealed pH of 7.29, PCO2 of 59.4 millimeters of mercury, PO2 was 52 millimeters of mercury, and bicarbs were 28 millimoles per liter, and his CRP was positive. In his sputum examination on gram stain, there were gram-positive cocci in pairs.
Any radiology resident? Please describe the X-ray.
Such as radiograph, frontal and lateral projections have been given. In the frontal projection, there's a hyperinflation of bilateral lung fields. That is evidenced by a flattening of the hemidiaphragm. At least 8 to 9 anti-ribs are visible. There's blunting of the right rostrophrenic angle. That must be likely due to the flattened diaphragm and prominence of the diaphragmatic slits. The few prominent interstitial opacities that are visualized predominantly in bilateral lower zones of the lung. On the lateral chest radiograph, there's again flattening of the hemidiaphragm. There's increase in the retrosternal clear space that is seen approximately 3 centimeters below the mandibular-sternal junction. And again, the sternophrenic angle is more than 90 degrees, and there's blunting of the posterior costophrenic angle. On the lateral chest radiograph, there's prominence of the trachea as well. The AP diameter of the trachea appears increased. With these hyperinflated lung fields in the clinical background, it fits into the findings of COPDs.
ठीक. So the X-ray shows basically hyperinflation, including the lung fields are hyperlucent. The diaphragm are flattened both on the PA as well as the lateral projection, and the retrosternal distance is increased to more than 2.5 centimeters. Next.
On 2D echocardiography, his left ventricular ejection fraction was 60%. There was no regional wall motion abnormality. There was no aortic stenosis, mitral stenosis, aortic regurgitation, or mitral regurgitation. The intraatrial septum and interventricular septum were intact. His right RVSP was 30 plus RAP, and there was no pericardial effusion, clot, or vegetation. In his final diagnosis, he was having acute exacerbation of COPD with pulmonary hypertension with acute on chronic type 2 respiratory failure.
The surgeon left it down to Abhishek. How will you differentiate between a COPD exacerbation and the other differentials? What are the other differentials?
So differentials for COPD exacerbation, we can consider either patient can have other obstructive airway disease like bronchial asthma. Patient can have parenchymal lung disease like pneumonia. They can have even bronchiolitis. Pan-bronchiolitis can also manifest.
Something much more commoner. Much more common things. And of acute, the acceleration will present acutely, na? So what are the acute presentations of breathlessness?
So we can have pulmonary thromboembolism. We can have acute left ventricular failure, which can manifest with similar kind of features, and acute exacerbation of pneumonia can also.
So how will you differentiate a pneumonia from a exacerbation?
So COPD exacerbation will have a background history of chronic cough with expectoration, while pneumonia will generally do not have a chronic history. The cough in presence of pneumonia usually is given as brassy cough, which is present, while in a COPD, it can have cough with expectoration, which can have variable type of manifestations. On clinical examination, presence of hypercapnia is more common in COPD, while in case of pneumonia, type 1 failure are more common than type 2. That is, hypoxemia is generally more common than